Good afternoon, everyone, and thank you so much for being here today. I'm Cara Hertz, Executive Director of Alumni Relations at Gonzaga, and it's my pleasure to welcome you today in partnership with my colleagues in the Center for Undergraduate Research and Creative Inquiry to our Distinguished Alumni Speaker Series and our first ever virtual speaker series event. Some of the best and most exciting work we do here at the university is working together and collaborating to engage, support, and connect our students with accomplished alumni in the fields they aspire to in their own careers. And today's event is a partnership with our distinguished alumni speaker, emeritus faculty, our students, academic partners, and this is just so exciting for us. And now it's my pleasure to introduce and turn the microphone over to my colleague, Dr. Matt Cremines. Dr. Cremines is a professor in Gonzaga's Department of Chemistry and Biochemistry and currently serves as the director of the Center for Undergraduate Research and Creative Inquiry. Welcome.
Thank you, Cara. So as Cara stated, I'm Matt Cremines. I'm here to introduce Dr. Kei Nakamaya, who served as a chemistry professor for 40 years at Gonzaga. He served as Dr. Mary Kamb's thesis advisor, and he served GU by building a community that transcends time. It is a privilege and honor to witness the lasting relationship built so many years ago. And with that, I would like to leave it, pass along to Kei.
Thank you, Matt. It's a real privilege for me to introduce a former advisee student as our distinguished alumni speaker today. As I recall so vividly back in those days, one of the first things that struck me about Mary was her uplifting, beautiful smile. You can see she still has that. She was a quiet and humble, but very thoughtful, introspective student. She took advantage of every opportunity she could to experience anything new. And she had in mind her ultimate goal of impacting her world as well as our world. After graduating from Gonzaga and also graduating from the University of Washington Medical School, Mary went to Massachusetts Brigham and Women's Hospital, where she did an intern and residency. And my guess is at that time learned how important research was for advancing medicine. And her ultimate goal was to help and the welfare of mothers and children, particularly in underserved and underdeveloped areas and countries. With this willingness to use her strong intellect and commitment, and also a lot of hard work, Mary earned a fellowship to the Fred Hutchinson Cancer Research Center associated with the University of Washington Public Health, and earned a degree there as well as studying cancer epidemiology. And this really prepared her, I think, for her calling clearly to go to the CDC, where she could have a global impact on healthcare for women and children. She became, over many, many years, a global authority on many infectious diseases such as HIV, many STDs, tropical diseases. And her accomplishments are far too great really to go through here. One primary example, which I find very impressive, is that she directed the institution of the HIV program in Vietnam, and that ultimately became a model for many other countries, and she should be very proud of that, as well as all of her other accomplishments. Her success has led to her current position now as the leader of Epidemiology research team, supporting the elimination and control of neglected tropical diseases, predominantly parasitic diseases. Somehow, she also found time to teach courses at a number of institutions, mostly on public health and diseases. She also mentored a cadre of public health scientists and physicians, and I'm sure did a good job of guiding them through their careers. Today, she's going to take us on a ride on her magic carpet. So I give to you here now, Dr. Mary Kamb. Thank you, Mary.
Oh, thank you, Kay, for that amazing introduction. I'm sure I've never had such a nice one. And it's just really a great honor to be here. Thank you all. And it's a great honor to be introduced by Dr. Nakamaya, who's a big reason I decided to major in chemistry. So I'm not sure if faculty are aware what a big effect you have on your students, but I can attest you have a huge effect. So I also want to thank the Alumni Relations and the Center for Undergraduate Learning Committees for your invitation. It's really a privilege to be here. So here we are in the middle of a global pandemic, and it's affecting all of us in every manner. And it's an opportunity to think about public health and its place in our world. And public health is interesting because it's invisible if it's working. We don't see illness or deaths or long lines for vaccinations if things are working. But this pandemic has kind of ripped off the blinders and showed us that our public health systems are not as strong as we'd like. So I'll be talking to you about public health research and getting at some of the basic issues that we deal with in outbreaks like COVID-19, and using a few of my own stories at CDC to help show these. So I haven't had a chance to visit Gonzaga for quite a few years, so I decided to use the opportunity to do a virtual tour, and I recommend it. It was great, but quite a few things stood out looking at Gonzaga today compared with the 1970s when I was a student. And the first thing is that the campus is absolutely gorgeous. I hardly recognize it. Everything's big and beautiful, and like this stunning entrance where Boone Avenue used to run. It's gorgeous. So the Gonzaga that my classmates and I attended was a lot smaller. There were only about 2,500 students, and it had a much smaller footprint, basically from Catherine Monica to St. Al's, and then from Boone Avenue to the baseball fields. That was it. So on the virtual tour, I didn't recognize a lot of campus, frankly, but there were a few things. The spires of St. Al's look about the same. Bing Crosby's still there, kind of gazing into the future, the past, although there's a new Foley library. And there were still messages on the wall, pretty tame ones, I have to say, not as radical as I remember back in the 70s. And then, of course, there's the bulldog. I have to say, I feel like our 70s bulldog was a little friendlier looking or less ferocious or something, but this guy's, he's clearly doing a great job. And I'm like all of you, I'm a huge Zags fan. And of course, I follow basketball, both men's and women's, and they're both phenomenal. So I'll go with this guy. So I lived in Catherine Monica, which seems, on the tour, it looked like it looked about the same, frankly, at least on the exterior. And this is an old picture of next to Catherine Monica of some of us chemistry friends, and also my roommate Tara, who we always conscripted. And we're just across from the dorm, and the baseball fields and the COG, which is the student union building back then, are in the background. And then I put in this phone booth to remind us how communications have completely changed. It's pretty weird to remember that this phone booth is how we talked with family and friends. We didn't have cell phones then. We didn't have landlines in our rooms. There was no internet. So of course, no social media or even email. So speed of communications and even expectations on speed were really different than from today, when we want news right away. And I was pre-med, you heard, and I majored in chemistry, and the department was pretty small then. I think just 5 faculty members, Dr. Nakamaya, and 15 majors in my class. I think mostly men, just 3 of us were women. And the faculty, they were demanding, but very supportive, super supportive. It was a great major, but it had this one nightmare requirement. We had to complete a senior thesis. So This is a younger Dr. Nakamaya back in the 1970s. So the Gonzaga team who invited me asked if I could share some thoughts about my undergrad research and how that's affected my career. And I have to say I was a little worried because the details are pretty fuzzy. But they very kindly dug my thesis out of the archives and they emailed me a copy. And I had to laugh to see it. Here's the front page. It's all carefully typed out on the manual typewriter. And I'm not going to talk to you too much about this thesis, but I wanted to show you a few pages so you could see what it was like writing scientific reports before word processors or before graphic software. It's all done by hand, and it's pretty interesting. So like this graph, all measured out and drawn by hand. So if you had asked me back in 1977 what lessons I learned, I might have had these points, which are, first, my thesis advisor that I started out with was an oncologist at Sacred Heart at the hospital, and he was really busy, too busy to meet very often. And fortunately, I was able to conscript Dr. Nakamaya and Dr. Kelsch as advisors. And my initial topic was super complicated, and I had to revise it to a more feasible study question. And this is a pretty common mistake of young scientists, but our advisors help. And point 3 is pretty obvious to any 5-year-old today, but for some reason, as a college senior, I still didn't know how to type, but I did at the end of my thesis. But I realized there are some more important things I learned at Gonzaga that I use today. And one of them, considering COVID-19, one of them is scientific method. So in chemistry, we were asked to conduct experiments, and a lot of our experiments failed. And doing these really helped me understand pretty viscerally that science is a process. It's an iterative process, and it's not a single outcome. And it's really small steps that we make in the direction of understanding natural phenomena, but it's step by step and building on studies that have been done before. And it's a slow process, and it's frustratingly slow in some ways in our pretty instant world today. So it's getting at this issue of scientific method. So we're getting at, in science, we're getting at this objective process of conducting experiments. And you know the steps, the developing the hypothesis and conducting an experiment and carefully observing, measuring, and documenting results and evaluating the findings and then using them to refine our hypothesis. And then starting again with a better hypothesis. And this method is pretty much exactly what my college and I use today in public health research. So I was pretty fortunate to experience this firsthand with great faculty, but these basics are things that everyone really has to understand, whether we're scientists or not, because we all need a basic scientific literacy in our daily lives. So today, in the age, where rumors travel in a single post, sometimes it seems like some bizarre idea gets the same consideration as a 5-year study in a peer-reviewed journal, and that's really a problem. And then there's an issue that research papers can have conflicting findings, which can give the impression that science doesn't really know what it's doing. But scientific literacy really prepares us for these and helps us understand that all methodologies aren't equal and that conflicting findings are really part of the self-correcting and the collaborative nature of the scientific method. So conflicting results really help us improve our hypotheses and conduct better studies, and this moves science forward. So scientific literacy, important. But for us scientists, this method also informs us. We have to be pretty careful not to be too dogmatic. And I even say that to us in public health. We usually don't have the truth. We might have the best evidence for the moment, but better evidence is always coming down the pike. So we need to be humble about what we don't know and honest, or else we'll lose the public trust. So there were a couple other gifts that Gonzaga gave all of us, I think. And one is that Jesuit ideal of social justice. And I think graduates then and probably today were really called to consider community service, and not just theoretically, but in practical ways, and working within communities. And in fact, many of my really good friends joined things like the Jesuit Volunteers or Teach for America, Catholic worker movement, the Catholic Legal Services, and they were really inspirational for me. And I know many grads today go into the Peace Corps, and as an alum, that makes me really proud. And the other giant gift that Gonzaga has given me is great lifelong friends. So my Gonzaga friends are still among my closest people, and I know this is something I probably share with a lot of you here. And we still get together often, even if it's Zoom these days or just texting during a ZAG game. And they are huge, they're a huge source of support. In fact, a lot of you wrote me email last night, and I thank you all. And I took my cat filter off. So yes, there are so many ways that my Gonzaga education continues to support me and help me grow. So public health. So there is a saying that goes, may you live in interesting times. And I think we're all understanding that this may be a curse. But I'm sure the world will be talking about this pandemic for the next 40 years and more. But 40 years ago, when I was at Gonzaga, it was also interesting times. And many of the things that happened way back then still have echoes today. The news then was all about Watergate, and we all learned the word impeachment for the first time then. And Hank Aaron broke Babe Ruth's home run record, which was major news and also hard for some people to accept. So here in Atlanta, we just lost Hank Aaron this past January, and he was an active and beloved member of the community here. And the city really still misses his spirit. And I had to put it in because I'm a huge Queen fan. The rock group Queen were newsworthy then, and nobody liked them except me. And now they're even more popular than ever. And then we celebrated the nation's 200th birthday. So, but there were in those same years a series of public health events that I was a lot less aware of, and these are milestones that still affect us today. And they included a controversial swine flu outbreak in 1976, and the discovery of Ebola in Central Africa the same year. That was when we first identified Ebola. And then the eradication of smallpox. The last wild case was in Somalia in 1977, and that was the year I graduated from Gonzaga. So eradication of smallpox is still among the greatest public health achievements ever. And it was, without a doubt, the deadliest disease in human history. It probably killed 3 billion people or more over the course of human history. So fast forward, you heard I went to med school and medical residency, and I did a fellowship. And then I was offered a chance to do a 2-year stint in the EIS program at the Centers for Disease Control in Atlanta. And this is what CDC looked like when I first came there in 1989. It was a few kind of post-World War II brick buildings next to Emory University. So CDC is our nation's public health agency, and it's the only federal agency with a headquarters outside of Washington, D.C. And as federal agencies go, it's pretty young. It started in 1946, and that's many years after the NIH, the National Institutes of Health, or the FDA, the Food and Drug Administration, which are the other big agencies that make up health and human services. So a couple things about CDC. It mainly exists to support state health departments, and it's an advisory agency, not a regulatory agency. And that means CDC scientists look at the scientific evidence and they provide recommendations. But in most cases, CDC doesn't have the authority to require people or states to follow those recommendations. The regulatory authority belongs locally to states or territories or tribal nations. They determine laws and policies. So another thing is that CDC's recommendations are based on available science. And when the science isn't available, on expert advice. So they routinely get input from experts from outside the agency and all different types of scientists, but also community leaders to help develop recommendations. So what is public health? So at its root, it's the science and the art of preventing disease, prolonging life, and improving quality of life. So it's really a combination of science, which is available evidence, and art, community values, judgments on how to apply the evidence. The World Health Organization, or WHO, goes on to say that public health is not only absence of disease, but presence of well-being. And CDC points out that it's a science of improving the health of people and their communities, so populations rather than individuals. And medicine deals with health in individuals, we know, but public health is about health in populations. So the public here can be a city or an entire nation, or in the case of our pandemic, the entire world. And it's interdisciplinary because it needs to consider the range of issues that affect affect health in populations, and not just communicable diseases or personal risk factors, but all of these other issues and more that affect health in a community. And the most effective public health programs have these three elements: a good roadmap or vision, and regardless of the health condition, an underlying tenet, really, an underlying basis is that the basis of public health is to achieve health equity. And second, public health research, the applied science of collecting data and developing effective interventions and evaluating them. So data and research are integral to effective public health programs. And then public health response, which is managing the intervention as it's rolled out. And this is the logistics and the organization, the supplies and trained personnel and the oversight. And embedded in there is the idea of partnerships. Community partnerships are really essential to an effective public health response. So I said I joined CDC as part of the EIS, which stands for Epidemic Intelligence Service, which are CDC's disease detectives. And the name sounds pretty weird, doesn't it? Is it like the CIA? Not at all. And in fact, it's probably the most fun job I've ever had, so far anyway. So EIS officers usually, they come to CDC with a doctoral degree of some time. It's not always medicine. And they come for specialized training in responding to outbreaks and serve for 2 years. The investigations they do are called EpiAIDs, and it's called shoe leather epidemiology because officers work on the ground with local public health staff and they work with the community. So it's not a desk response. It's really being right there at the outbreak. And EIS officers are assigned either to CDC headquarters in a division, a disease-specific division, or they're assigned to a state health department and they work with the state epidemiologist. And these state jobs are especially good because there's such a variety of things, outbreaks and other things that happen in the state. So the scientific method that EIS officers use is epidemiology, which is a tool that is used to find the causes of health outcomes in populations. So EPI investigates what factors determine presence or absence of disease in the community. So here the patient, quote unquote, patient here is the community. And it helps us understand diseases and how they affect communities. So in other words, EPI is studying who is affected and what are their symptoms, when did they occur, why is this happening, which is getting at the factors determining this disease in this community. And then most importantly, how can we effectively respond to this problem? And it's doing this with systematic data collection. So EPI is a new field. It came out of the mid-19th century. It's been ascribed to an English doctor named John Snow. And in the 1850s, London had several outbreaks of cholera. A very vicious disease. People develop massive amounts of water diarrhea, and it's so severe that they become very dehydrated quickly. And in fact, cholera can kill healthy people in less than 24 hours. So today we know cholera is caused by a bacterium, but this was before germ theory, and so no one knew what caused it. And there were a lot of theories, you can imagine, but even the medical establishment thought that it was related to something called miasma, which is bad air. So in the summer of 1854, there was a terrible outbreak of cholera in London, in the London district of Soho. And by the end of the summer, over 500 people had died. And now John Snow lived in Soho, and he knew that not everybody with cholera had been outside breathing bad air. And he had this theory that cholera was spread in water, but he needed evidence. So he went door to door recording the deaths at each address, and then he assembled the data and he made this map. And this is a little hard to see, but this is Soho, and the yellow area is Broad Street, and you can see tiny black squares. Each of those represents a death. Some houses have just a single death and some have many deaths, but the deaths are all concentrated around the red rectangle in the middle of Broad Street, which is where the community water pump was. So John Snow concluded that the cholera outbreak was related to this particular water cistern, and to prove his point, he removed the water pump, the pump handle, and the cholera epidemic stopped. So this is a demonstration of this new science, epidemiology, that uses on-the-ground data from maps and surveys and not just lab experiments to understand causes of disease. And really, it's the same basic tool we use today to understand and predict outbreaks. So today we use maps, but we also often use this type of graph called an Epicurve, which shows when an outbreak occurs and how it's distributed over time. So these graphs have time along the x-axis on the bottom and number of cases on the y-axis, the vertical axis. And this is an epicurve of a multi-state cyclospora outbreak that happened this past summer. So, cyclosporiasis is a gastrointestinal illness that's caused by a parasite. And people get infected when they eat food that's contaminated with the parasite. And the carrier is usually some type of fresh produce like lettuce or cilantro. And the peak of this past year's outbreak was on June 4th. There were 59 cases. You see the tallest peak. And there was a response, a health alert went out and some tracebacks with FDA, and the outbreak petered out. So this is another Epicurve, and it's looking at US COVID-19 cases since January, a year ago, January 2020. And like the one we just saw, it graphs the number of cases reported each day. The x-axis has time, the y-axis has the number of cases. It's a little hard to see the numbers here, but here cases are in thousands. So the daily case numbers are representing hundreds of thousands of cases each day. And this time we don't see a bell-shaped curve because the outbreak's still going on. And in fact, we're seeing waves of cases that are getting higher. And you can see the spikes are happening after major holidays like Memorial Day and Thanksgiving and Christmas, and which is suggesting that when people gather at holidays, it increases spread of COVID-19 in the community. Now, we can't prove for sure that with a national Epicurve, but these trends can help us think about doing special local investigations to check that hypothesis out. So at CDC, my work has mainly been public health research, that first bullet there, gathering data for action and developing and evaluating interventions and reporting on results. But I've also had an opportunity to work on some public health responses. And I'm going to share a few stories of work in 3 areas: in domestic and global HIV/AIDS, and then a short stint I did working on global polio that was really interesting, and an example of my current team's work. It's in, as Dr. Nakamaya mentioned, in elimination of neglected tropical diseases, or NTDs. So I actually couldn't find a picture of me during EIS, but this is a former EIS officer who happens to work for me now, Sarah Gualiardo, and she's giving a video on how to pack for an EPA. So for EIS, I was assigned to work for the Division of HIV STD Prevention, and I was thrilled because I really wanted to work on HIV and AIDS. And this is an old copy of CDC's Morbidity and Mortality Weekly Report, or MMWR, and it comes out weekly. It's a fascinating read. It still comes out. It's interesting to read if you're interested. But this particular report describes a very famous EPA that was done by the EIS officer assigned to Los Angeles back in 1981. And that's before my time at CDC. I was still in med school, but we were all aware of this report. It completely rocked the medical world. This is the first published report describing a new disease that turned out to be AIDS. So this investigation centered around 5 previously healthy young men in Los Angeles, and they all had developed a very rare type of fungal pneumonia. And all the men were severely immune suppressed, but no one could really figure out why. They shouldn't have been. And they came from 3 different hospitals, different parts of the city. They didn't know each other. There wasn't any clear connection between them. But the one thing they had in common was they all reported having sex predominantly with men. So it's 1981, and the world wasn't sure this was an infectious disease, but it sure looked like it. So we wouldn't identify the virus that caused this, HIV, until 2 years later. So back in 1981, this syndrome was called GRID, or gay-related immunosuppressive disease. And as a medical resident in Boston, I had scores of patients with this syndrome, mostly young men. It was hideous because they were profoundly immune suppressed. And they get infections that were so rare that my attendings, who are the supervising doctors, they may have only seen that case once in their life or have only read about it. So we saw lots of these, though, and it was a really relentless disease, because even if people got through this infection, they came back with another one, and our patients were so young and they were all dying. And then fairly quickly, GRID began to affect some of my friends and colleagues in Boston and then in other parts of the country. So it was really a very scary time. So the first HIV test wasn't developed until 1984, which is right at the end of my residency. And with testing, we began to realize that we had hundreds of cases in the United States. And even more, this was a giant global epidemic. And we realized that the virus was not just spread through sex, but with blood exposure, blood products from mother to child and pregnancy. So that's a bit of a long story, but it was because of that experience that I really wanted to work on HIV when I came to CDC. So as a new EIS officer, one of the first outbreaks I was sent on, and with another EIS officer, was in South Florida, where there were some unusual HIV cases that the health department thought were transmitted heterosexually. And at CDC, people were pretty skeptical because this was still considered a disease of gay men. My colleagues and I worked with the state health departments and we were working in the communities of Homestead, Liberty City, and Overtown, which are some of the poorest neighborhoods I've ever seen, frankly. And we found many people with HIV who were not gay men, and some people had personal risk factors that might explain their infection, but many had no clear risk factors. And most of the people we interviewed didn't know they were infected or even at risk for HIV infection, let alone able to spread it to others. And most people were very young, and very few had access to even basic health services or HIV testing. So it was pretty clear that regardless of the proximal cause of infection, the root causes of HIV in these communities were poverty and poor health infrastructure. And lack of good information and stigma also played important roles. And these are problems that we still grapple with in HIV in this country, all these years later. So today we realize that HIV, it was a new virus. It jumped species from a virus affecting another animal. And since it was identified, it has killed more than 35 million people globally. And there are still about 40 million people living with HIV in the world today. And the United States, you see, represents just a fraction of these. Most are people living with HIV are in sub-Saharan Africa or Asia. So there really has been remarkable progress in HIV testing and treatment over the years, but we still don't have a vaccine and we don't have a cure. So a lot to do. So after EIS, I stayed at CDC and actually most of my career has been working on HIV, either here in the United States or globally. And in fact, some of my most satisfying work has been with health ministries in Africa and Asia. Dr. Nakamaya mentioned Vietnam. That was a great job. So I wanted to give you an example of public health research on HIV. This was an early collaborative project that was led by WHO and UNAIDS and several other national health ministries. And my role was pretty limited, but I wanted to show you this because I think these data are so powerful. So this shows the life expectancy for people in 5 African countries from 1950 to 2005. This is before effective treatment for HIV in these countries. And this is national life expectancy. So it's not in selected people, this is the nation. And the x-axis shows time in years and the y-axis shows years of life expectancy with 35 years as the baseline. And each of the colored lines represents a different country. So what we see is that in 1950, life expectancy was pretty low in these countries, just 40 to 50 years. But with public health programs like smallpox and smallpox eradication, safe water, childhood immunizations, Life expectancy in all of these countries rose substantially until just before 1990. And then we see this dramatic drop in life expectancy, and these drops are entirely due to AIDS. So one disease wiped out decades of public health progress. So since 2005, these numbers, the life expectancy, have begun to creep back up, but they haven't yet reached what they were in 1990. HIV is still a major force affecting Africa. So another area I had a chance to work in briefly was global polio eradication. And that was a program that grew out of the success of smallpox. The world got really excited that maybe other diseases could be eradicated, like measles, which kills so many children, or polio, which maims so many, like the children in this picture here. So in 1988, the world banded together on an effort to eradicate polio by 2000, and it was led by a group of very strong partners that are listed here. And the spoiler alert is polio was not eradicated by 2000, and in fact, it's not yet eradicated. And that's another story, but there have been some big successes. So polio cases globally have dropped more than 99%. And in fact, last year, there were just 200 cases of wild polio in the world. And this past year, Nigeria, the last country in Africa with polio, had its final case. So wild polio continues to exist in only 2 countries, Pakistan and Afghanistan. And the problem is that this is an infectious virus. So polio remains in one country, all countries are at risk because an infection could be reintroduced. And that means all countries have to keep vaccinating their children. So in 1998, which is about 10 years into global polio eradication, CDC partnered with WHO on a new program that was called Stop Transmission of Polio, or STOP. And CDC staff were essentially lent to WHO for about 6 months to go to countries that needed support. And I was invited to join the second STOP team. There were about 40 of us from CDC sent to 5 countries, and I was sent to Nepal, which is a beautiful place, but at that time, desperately poor, and it ranked second to the last in the world in childhood mortality. So the country lies just above India. The capital is Kathmandu, and I was assigned to work with this man here, Dr. Jesuit. He was the immunization officer in charge of the entire central region, which is just a huge job. And we mostly worked on the Turai, which is the lowland belt of Nepal that abuts India. It's brown on the map here. And it's the most populated part of Nepal. And at the bottom, I have a picture of the road from Kathmandu to Turai. It was a pretty grueling 9-hour drive down these deep canyon roads, very bumpy, lots of hairpin turns, lots of waterfalls. The road was washed out all the time. So I worked with Dr. Giddy for about 6 months, and we didn't make it to Kathmandu very often. But our job was to detect new cases of polio and strengthen the immunization program. So we did this by visiting 55 health centers in our region every week. So we were constantly on the road. And in health centers, we looked through logbooks for evidence of new polio cases, which present as acute flaccid paralysis. And people suddenly become limp and they can't move. So if we found a suspected case, we planned to vaccinate contacts and kids at our next visit to the village. And at every visit, or at every village we visited, Dr. Giddy took the opportunity to gather people around and talk about polio and immunization, and I'd look through the logbooks. So this is the Turai. It's very flat. It's farmland mostly, and we were usually the only motor vehicle on the road because most people used ox carts, or they used bicycles, or they just walked. So people, women were usually walking, and many had infants on their back, and they almost had these, always had these big baskets full of something, either laundry or food, going to or from the market. In the rainy season, there were these shallow rivers that popped up, and people used them for everything, for drinking water, for bathing, for washing clothes. And you can imagine that an intestinal virus like polio could be easily spread. And in the dry season, these rivers just disappeared, and people used them for roads. So the villages were very simple. There were hardly any houses. Well, hardly any houses had electricity, and hardly any had running water. So they used central wells. And sometimes the hospitals didn't have electricity or running waters either. And this is what it was like when we visited a village. People, and it was mostly women and children, would gather around to see us, and Dr. Giddy would give us pep talk. And I didn't speak any of the local languages, and probably my biggest asset was as a draw, because people wanted to see, you know, the white lady doctor from America. But Dr. Giddy was a popular speaker, and he was so effective. And this guy's really something else. He's a brilliant clinician. He speaks 9 languages fluently, including English. And he really is pretty typical of the type of public health leader that exists all over the world, working on disease elimination. And at the bottom, you see him giving an oral polio vaccine to a child in a village where we found an AFP case. And so all of these villages had Rotary clubs. Did you know Rotary's basically everywhere? And the village leaders all belong to Rotary. So this has been a really effective partner for polio. And was it worth it? Well, Nepal eliminated polio in 2000, and they were able, then right on target actually, 2000, and they were able to use their data to demonstrate that by focusing on polio, they also reduced other childhood vaccine preventable diseases like measles and rubella. And this is a little hard to see on the Epicurve, but I put a red arrow at the year 2000 when Nepal eliminated polio, and then surveillance continues, and years are along the x-axis there on the bottom. And numbers of cases again on the y-axis. And over time, we see fewer and fewer outbreaks of measles, which are in light green, and fewer outbreaks of rubella, which are in dark green. So these data show that in Nepal, polio eradication strengthened other childhood disease programs. So since 1998, there have continued to be stop teams every year going out to countries that still need them for surveillance and vaccine programs. And that's because we still need to be vigilant, because polio still exists in those 2 countries. And so all countries are at risk. So the last story I wanted to tell you about is this. Right now, I lead the CDC research team that supports global elimination of certain neglected tropical diseases, or NTDs. And we work with WHO on these, on 3 parasitic diseases of poverty, and it includes this one, which is onchocerciasis, or river blindness. So river blindness is caused by a worm, a filarial worm, and it's a little thread-like worm that's the larvae are spread by repeated bites with a type of black sandfly. And then the worm grows in humans, and the next stage of larva causes inflammation in people. And so they get itchy skin and then inflammation of the eye. And that can lead to vision loss and eventually blindness, like in this young woman. So onchocerciasis is curable if children are treated early enough with an antiparasitic drug. And countries that have the parasite could eliminate transmission, and that means break the parasite life cycle if they're able to treat enough infected people. And it only requires occasional treatment, so it can be done with community mass drug administration, or MDA, which are campaigns done once a year. And in an MDA, the entire community, which is everybody over 2 years old who could safely swallow a pill, takes a dose of the medicine. So I wanted to tell you about river blindness because it's a neat example of the power of partnerships. But this time it's a really unusual partner. It's large pharmaceutical companies. And I know we don't often think of big pharma as the good guys, do we? But the drugs used in the MDAs are donated free of charge to support elimination of NTDs like river blindness. And several big pharma companies have joined in. And in fact, this past January, the global NTD community celebrated that more than 1 billion people have been treated globally in the past 10 years, thanks to these pharmaceutical donations. So in African villages that have onchocerciasis, you often see a child leading an older person with a stick, and that's because the person is blind. And this statue is at the WHO headquarters in Geneva, and it celebrates global onchocerciasis elimination. And there's an identical statue at the headquarters of Merck, the global pharmaceutical giant. And I think this must be especially moving for Merck employees. So I showed you CDC when I first started working there, and this is CDC today. looks really different. The big buildings are on the left, there are the labs, and on the right is the main entrance on Clifton Road. And when you walk in the main building, we see this pledge on the wall when we walk in every day. It's the pledge the agency has made to the American people. And it reminds us all that we're all public servants. And honestly, you know, CDC has had a tough year. We all admit it, but it's weathering the storm. And I think most of us working there, including me, are glad to be able to contribute and proud to work there. So that's my story for you. And I want to thank you for your time and also thank Gonzaga for this chance to talk about my big passion, you can tell, which is public health research. And I have one last slide I want to share. This is a shout out to my parents, John and Wilma Kamb, and my daughter Maggie, and who's a junior at USF. And Maggie and I just visited my mom for her birthday last February, right before COVID. So our timing was so lucky. But now we're stuck in Atlanta and we're really missing them. So my dad went to Gonzaga, my mom to Sacred Heart, and they met here in Spokane. So I just wanted to give that shout out to them. Thanks.
We really want to thank you, Mary, Dr. Kamb, for an incredibly informative and fun presentation. So many great pictures, including your parents. That was really fun to see. But we're just so grateful for your time today. And also Dr. Nakamaya, I know you want us to call you Kay. You are beloved by so many of our alumni, as Mary shared, and it's just been a real treat to have you with us today. And Matt, Dr. Cremines, thank you for your great leadership and partnership and really making this event possible today. And then to all of you for joining us, thank you so much for being here. Take care.